Okay. Good morning, sirs. Good morning, Mars. Okay. You're welcome to this presentation. We are about to start. Good morning, sir. Thank you so much for joining in, sir. I'm grateful.
You are welcome.
Thank you, sir. We'll just give a few minutes for others to join up. I'll go to the WhatsApp group and trouble them now.
Hello, good morning, ma.
Yeah, good morning.
Okay, ma.
Chief, good morning. Welcome.
Thank you, ma.
Yes,
so,
sir.
ma, you can start putting up your slides so that you can test run.
Okay,
so
okay.
Share your slides.
Okay,
while
sir.
we wait for others to join in.
Okay.
Then I don't know if Dr. Bashir. Good morning, sir.
He's already around.
Yes, good morning, sir. Good morning, Chief.
Hello, good morning.
Yes, sir.
Okay, can we start?
Okay, sir.
Yes, we can, sir. So, good morning, sir. Good morning to Dr. Bashir. He's general surgeon in Department of Surgery, and he will be with us this morning to help moderate the presentation. Dr. Popoola is giving the presentation on early management of abdominal injuries. So I'd like us to take notes and be ready for comments and get our clarifications cleared out. So thank you. Dr. Popoola, please, you have the floor. Let us be.
All right. Thank you very much, Dr. Toba. Good morning, sir. Good morning, ma'am. Thank you all for joining this presentation this morning. This morning, we'll be discussing the topic, early management of abdominal injuries. My name is Dr. Popoola Margaret, and my moderator is Dr. Bashir Yunus. I'm particularly very grateful to him for taking time out of his busy schedule to be with us this morning. You're welcome, sir. I'll be doing a presentation following this outline. Introduction, which will cover the function, mode of presentation, management, complications, through to current trends, and possible future trends. Early management of abdominal injuries is actually the level of care that is given to an individual with this kind of injury within the first 6 hours of the incident occurring. And usually it can be divided into two types, at which the individual assesses at the site of the occurrence of the injury or at the scene of the injury, and that which the individual assesses at the emergency room. But it all has to be within 6 hours of occurrence. And this morning, we're going to be focusing more on that care that the individual assesses at the emergency room. The abdomen, as we all know, is one of the body's largest cavities. Contains multiple vital organs. These organs are arranged in the abdominal cavity in various quadrants. and also either some of them retroperitoneally, some of them intraperitoneally, and some of them attached peritoneum or covered by omentum from the anterior abdominal wall. Abdominal injuries are of great importance as they may affect and physically compromise the function of any of the organs in the abdominal cavity. Most of the time, when bleeding occurs, large volumes of blood can be lost within the abdominal cavity even before signs and symptoms manifest. The surgeon must always bear that in mind while examining such patients. The surgeon must also be alert for signs of transmitted injury, which may show up as obvious deformity in the anterior abdominal wall or elsewhere, or show up as swelling. Swelling usually can be mild, and which may progressively become progressively increase, and the surgeon must take time to measure the abdominal fat at intervals to be able to note if there is increase in the abdominal fat that will point to increased accumulation of blood within the abdominal cavity. Other signs could be ecchymosis. There could also be irritations, particularly there could also be irritations, which usually occurs when there is a collection of blood under the diaphragm. Treatment of surgical importance. Abdominal trauma will occasionally present in such a way that emergency physician can form a reliable field impression. However, at other times, it may not be so. Regardless, even if the emergency physician is not sure of what is going on, he must always know what to do at every given time, particularly when he follows laid down principles in management of such conditions. Trauma is the leading cause of death from age 1 to 44. Most trauma to the abdomen occur as a result of blunt abdominal trauma and penetrating abdominal trauma. When considering internal bleeding and multi-system trauma, blunt abdominal trauma is consistently among the leading causes, and we must always bear that in mind. Overall, about 20% of such cases require surgical operation. Mainly, there are two types of abdominal injury, and they are the blunt abdominal injury and the penetrating abdominal injuries. This is a picture, though not very clear, but this is a picture showing a blunt abdominal injury. And this below, sorry, the orientation is not well oriented, but if you look carefully, you see that this is a picture of a penetrating abdominal injury with part of the viscous eviscerating above the anterior abdominal wall. Types of blunt abdominal injury can also be caused by a number of physiological factors, such as motor vehicular crash, that occurring from seatbelt injuries, usually, which can occur from a handlebar injury, as a bicycle. Then, of course, when there is fall from height, all of this can result in blunt abdominal trauma. Then, of course, for penetrating abdominal injury, most of the time we have stab wounds, which are usually low energy injuries. Then, of course, we can have gunshot wounds, which are usually high energy injuries. Mode of presentation usually can be either emergency presentation or the patient presenting as a stable patient who has suffered some form of abdominal injury. For emergency presentations, most of the time, emergency presentation can be either blunt, as a result of blunt injury, or can be as a result of penetrating injury. But usually, in emergency presentation, among a number of features that one may see, it could be coming with acute blood loss, bleeding out outwardly you can see that the patient is bleeding, or they could have occult bleed, which do not see visibly, or there will be external manifestations like may be severely pale, may be in shock. There could be patient may be in respiratory distress. There could be rapidly increasing abdominal like that. Patient may be in severe painful distress, and of course, some of them might be vomiting intermittently. But of course, for the stable patient, the vital signs are taken. Most of the time, the vital signs are all stable. That does not mean the patient does not require attention. He still requires attention. Then, when a patient presents as an emergency case, which is the kind of cases that we are likely to see more often in the emergency room here, when such people present, it is important that they need to be resuscitated immediately. Resuscitation is key. And for us to be able to resuscitate the patient properly and manage the patient properly, we should activate the ATLS protocol, that is the Advanced Trauma Life Support Protocol. We should activate that protocol to guide us in being able to give adequate care to that patient. And, this protocol complements the primary survey plus resuscitation, the secondary survey, and of course the definitive treatment. If the patient presenting is a stable patient, what we really need to do is to take detailed history and also to examine this patient properly, taking note of various signs that the patient may present with. Then when we have done that and we have established the diagnosis, we can now go on to definitive treatment. And primary survey and resuscitation. The first thing to do is always good to begin with a general impression of what the patient may be coming with, taking note of the level of the patient's consciousness. Then when we have done that, then we activate the HLS protocol as the primary survey, looking out for various variables. And those variables will be, we want to look at, is the patient bleeding? Is he bleeding torrentially? Is he having what is referred to as catastrophic hemorrhage? Then you have to make sure that you try to stop the bleeding. Then you want to look at the airway. Are the airways patent? Are there things obstructing the airways? Are there particles? Are there foreign bodies? That evacuate all of those things. Now, we must bear in mind that this protocol that we are activating will be doing multiple things at the same time. It is not just one thing. We'll be doing a lot of things at the same time. Keep this patient alive. While you are looking at the airway, we are probably going to be taking the vital signs, looking out for the patient, looking out for the patient level of saturation, looking out for checking his blood pressure to see that he's in shock or not, looking at the testing the checking for the pulse, the nature of the pulse and the count of the pulse, to know if this patient is in shock and all of that. Then, of course, by checking for the patency of the airway, we want to also careful about the cervical spine of this patient. We want to be sure that there is good cervical spine control. You want to put neck collar or a neck support if you suspect that there might be injury to the cervical spine. In fact, it is said that until proven otherwise, you should treat all such patients as having cervical injury or until it is proven otherwise. Then the next thing to look out for will be the breathing. Is this patient breathing? Is she breathing well? What is the nature or the character of breathing? You must note all of that. Then, of course, circulation. You want to create access, put 2 white ball cannulas for fluid for this patient. While setting up the cannulas, you want to take blood samples for a number of basic or baseline investigations. And of course, we want to check if there are obvious deformities that this patient have or obvious disabilities that this patient have, in addition to the primary situation that has brought the patient to the hospital. Then, of course, exposure also very important. Then, having completed the primary survey, after a short while, you go on to the secondary survey. In this secondary survey, you reassess the patient again to see whether there is an improvement or whether there is deterioration, whether your resuscitation parameters that you have set up, whether they are working, whether you are winning or not. So you assess the patient, your basic investigations, those samples you're taking, you activate, sending them to the lab so that you can start getting results very fast. Some of the basic investigations you might be interested in at this point is the heart cell volume. You want to know the level of blood that this patient has. Is he or she pale? Is there possibility of this patient being in shock or tilting towards being in shock? You want to do a full blood count to get a more general picture of the blood. Usually the heart cell volume will be like an urgent heart cell volume to see the level of the blood. Then later you can do a full blood count to see a more detailed picture of the blood. You want to go and cross-match blood for this patient who might be losing blood rapidly and might require to go into surgery any moment from that time. Then of course you want to do a focused abdominal ultrasound scan, which it is this fast is actually well recommended in acute situations like this, even when the patient is not stable. It can be done. Then you want to do a random blood sugar. Then of course, you want to do a urea electrolyte. You want to do a diagnostic peritoneal to see if there is blood or if there are bowel content or other things that go. And the purpose of this secondary survey is to identify significant injuries that you might have missed during the primary survey. Then, of course, you still continue the resuscitation that was initiated during the primary survey. Then, usually, all life-threatening conditions have been identified and addressed by this time. Then, you also check to ensure that the vital signs of the patient are actually normalizing. If they're not normalizing, you check for the reasons why they are not normalizing, why they're doing improvement, and then you act on correcting those deficiencies. The component of secondary patient assessment that we should be looking out for, that we should be doing, the airway frequency, just like the primary survey. We want to check patient breathing effectively now, unlike when he first presented. And you want to look at the then I want to if it can improve now, is it a strong then you want to come with there could be they could be running in some of them, but not all. Some of them will maintain normal body temperature. Then of course for capillary refill and color. These are the signs that you are winning in your resuscitation effort. Then of course you check for the patient's status. So you look out for any medical query that the patient may be bearing to provide information about the medical, because some patients may be in shock, they may not be able to give you the necessary information. If they have allergies that you need to know about, are they allergic to some drugs? Are they allergic to maybe some food items or any whatever? You want to know are they on medications that you need to know because of drug interactions when you are administering your own drugs that may affect your own drugs. You want to know, are they on maybe drugs for some long-term treatments? You want to know whether drugs they are on. You want to know if there are previous medical histories. Maybe they have comorbidities like diabetes mellitus. They could be epileptic patients, and because of this epilepsy, they may be on some drugs. Do they have heart disease? Are they hypertensive? You want to know all of these things so that it's in the background as you treat this patient. Then it will take definitive care. At this time, you have resuscitated the patient and the patient is stabilized. So you may need to repeat some of the basic investigations that were done previously. previously. And at this stage, we want to do more advanced investigation. We want to now have a basic surgical plan for this patient. Then you invite the surgeon to take over management. In our case here, we want to invite the surgical team on call first to review, then invite the primary surgeon that will take care of the patient. So what are those more advanced investigations that you want to do? You want to do diagnostic peritoneal lavage. This diagnostic peritoneal lavage is very helpful. It can give you a picture of what is happening in the abdomen, if there is blood, or if there is intestinal, if intestines have been ruptured and there is a bowel content in the fluid, it will let us know. They want to do an abdominal ultrasound scan, particularly the fat. Then you want to do a computerized tomography scan. You want to do a laparoscopy. You want to do a clearing abdominal radiograph. So the diagnostic peritoneal lavage used to be the standard investigation previously, but presently it is being replaced. It is being replaced very. It is being replaced all centers by the FAST, that is the abdominal scan, one that is the stomach.
How do you say why you saying? Something there like this, they say make. How do you wire the bomb?
What's in the bundle?
I mean, why bomb?
What's in the bundle?
You know the sometimes.
But however, it has a drawback. It can miss that pragmatic and retroperitoneal injuries. Oh, let's go back. Okay. Then, of course, we have the FAST, which is an abbreviation for focused assessment with sonography or trauma. It detects fluid or blood inside the peritoneal cavity. Its accuracy is comparable to the diagnostic peritoneal lavage. However, because it is non-invasive and repeatable, it has taken over. It is now more preferred than the diagnostic peritoneal lavage. It has also the drawback of being operator dependent, meaning there could be observable error. Then it also has the drawback of missing some specific injuries. And then, of course, if the patient in question is obese, then it may also give results that may not be very accurate. It has replaced diagnostic peritoneal unit command. Then the next investigation you might want to do is the computerized radial tomography. It documents specific organ injury, meaning it is an improvement over the past. Then it can also pick retroperitoneal, it can pick retroperitoneal organs, and it is very accurate. It can be done in only hemodynamically stable patients. However, its drawback is that it can still miss traumatic injuries and bowel injuries. At this point, you want to make a surgical decision. Your surgical decision is going to depend on three things. Whether your findings are normal abdominal findings, or whether there are obvious injuries to the abdomen, or what in an equivocal abdominal finding situation. You have to take a decision of what to do surgically. If there are normal abdominal findings, it is required that the physician should do a reassessment of the patient, a reassessment of the physical findings by the same experienced surgeon or physician who first assessed this patient, so that there would not be inter-observer error. You reassess this patient. Usually, once you reassess the patient and you are satisfied that the findings are still still normal, then you do a CT scan. You do a CT scan in a patient that is stable and who is awake and alive. You do a CT scan. When you have done that, then you can decide that, okay, this patient is normal. She may not require surgical intervention. For those ones that are unstable, you may do an abdominal scan or a diagnostic peritoneal lavage. Then it will guide you to take a decision that this patient does not challenge. Those with obvious injury, and this typically mostly applies to penetrating injury, because vertically or penetrating abdominal injury should be explored properly, especially in the presence of hypotension. Then you do a lot of exploration, laparoscopy, for bone wounds, also laparotomy. Then you do a CT scan. Now, most of this, for instance, like the laparoscopy I'm mentioning now, is not going to be for the emergency physician, but you have it in your mind that, okay, this patient is going to require laparotomy. So you have to start working up the patient with that in mind while you try to invite the surgical team on call to over the management. Then for equivocal abdominal finding, if the patient is hemodynamically unstable, you do a diagnostic peritoneal lavage or you do an abdominal scan. For those that are stable, you do a CT scan. Then when you have done this, you then reassess the patient based on the findings. It will now guide you whether this patient will require surgery or not. So early management in surgical emergency. These are the things we have to do as emergency physicians in the surgical emergency. When we get such patients, the first thing to do will be take a brief history and examination, and we activate the advanced trauma life support protocol, which includes the ABC of respiration. That's we clear the airway, we put patient on oxygen if the patient is desaturating or the airflow is low. We set up lines, we take up samples for investigation, we check for other disabilities or comorbid conditions that the patient has. We inspect the wound thoroughly, we irrigate and we take clinical photographs. Then we pack the wound with moist, appropriate covering, usually some gauze with normal saline sprinkled or poured upon it. Then we now place it over the exposed viscous. So this is just a picture. This is a picture to show us an example of a surgeon or an emergency physician trying to cover an exposed abdominal eviscerated viscous. He has a gauze in his hand and he's putting normal saline. And he's putting normal saline. And in the viscous, like he has covered the abdominal viscous with the moist covering. And please permit me to say that in a few minutes, this presentation will go off, but we have to immediately click the link and re-enter the presentation back. Thank you. So, continuing from what I was saying, you put patient on nail pairs. You pass in a gastric tube, which can be for drainage. Then, of course, you pass, and it is very important because some of these patients also vomit intermittently. You don't want them to aspirate the vomitus. It will cause more problems for you. Then you want to pass a rectal catheter. You want to do investigations, as we have already explained previously. You want to transfuse the patient as may be necessary. Then, of course, you want to commence preliminary treatment. Now, it is important that this patient should have adequate analgesia. There should be a good broad spectrum antibiotic. The patient should be given the tetanus prophylaxis. Then, of course, you invite the surgical team to review. Basically, these are the things that an emergency physician in the emergency room should do before the primary surgery. For a stable patient, usually you may want to go use a conservative management approach. Usually, such patients, the abdomen may be normal, or there could be liver injury, maybe from grade 1 to grade 3. For such, or there could be chronic injury also maybe from grade 1 to there could be something. Depending on what is seen, you may want to involve the interventional radiologist who has the capacity to do a non-invasive procedure or a minimally invasive procedure to arrest the situation. Or it is also that we must we must always beware of concomitant solid and hollow organ injury occurring, because they occur most of them, about 7% of these injuries are concomitant hollow and solid injury injuries. So we must always be aware that such conditions can occur. When they occur, they present a management challenge. So we must always be careful in how we approach such management of such conditions. Then there is what we call the urgent surgery. Radiological evidence of intraperitoneal gas, if present, is an indication for urgent surgery. Radiological evidence of ruptured diaphragm, if present, is an indication for urgent surgery. Others are gunshot wounds, evisceration of the abdomen of the discus. Then, if there is a positive result on diagnostic peritoneal lab, it's an indication for urgent surgery. Then, of course, when you have a rigid, silent abdomen, or when the patient is in unexplained shock, you are resuscitating, but you are not seeing the result, the patient is not improving, then it is an indication for urgent surgery. The aim of urgent operation is usually the aim of urgent operation is usually for hemorrhage. It's usually for hemorrhage control. It's usually for contamination control, and of course, it enables you the opportunity to do an anatomical repair of the ruptured discus or the part of the abdomen. Then, of course, hemorrhagic control plus contamination control minus anatomic repair is what is termed damage control surgery. That is when you do a hemorrhagic control, you do a contamination control, but of course, you don't go into anatomic repair. It is called damage control surgery. So damage control surgery, on a broader term, it is the term used for it's a temporary abbreviated surgical control, meaning there are still other problems, but you are not interested in those problems for now. You just do the minimum thing you can do to keep this patient alive until a later date. So it is also, it can be referred to as a focus on restoring the function of physiology. Then you can also look at it as a situation that you defer treatment for structural and anatomical destruction. That means those ruptures or tears, they are not what you want to target now. They will be for later, after you have helped the patient to be alive, stable. Then you can also refer to it as a temporary abdominal closure, because you know you are going back to take care of the problems you have left. An inability to achieve hemostasis, particularly in liver injury, because it's one of the big challenges that the surgeon has in intra-abdominal surgery when there is liver hemorrhage, or when you want to do a surgery around there. There's something they call the Pringles maneuver that the surgeon uses to try to make sure to achieve hemostasis during such surgery. Then, of course, combined vascular, solid and hollow organ injury, as I alluded to before, you have to apply damage control surgery. Then evidence of poor physiologic result when the patient has that damage control surgery. I just want to touch a few things, like when there is specific organ injury, like when there is hepatic injury, mostly the grade 4 type, when there is a hepatic avulsion. Okay, I mentioned Pringles maneuver. It is actually the occlusion of both the inflow to the liver that is the portal vein and arteries, doing that to achieve hemostasis. Then when there is any injury like grade 5, when there is a shattered spleen or hilar vascular injury, or when there's pancreatic injury, so pancreatic injury. So all of these are situations whereby there is specific organ injury, and the surgeon must be involved in the management of this patient because it will require surgery. And of course, when there is compartment syndrome, it is usually very rare, but deadly when it happens. The surgeon must be invited, the surgeon must be in the management of this. And what are the number of contraindications that have been seen? Laparoscopy. Laparoscopy is contraindicated in hemodynamically unstable patients. Then interventional radiology is contraindicated in hemodynamically unstable patients, except you have done a damage control surgery and this patient is now stable. Then you can invite the interventional radiologist to come in and do his procedure. A number of complications can be seen in this situation. We have recurrent bleeding, we have hemophilia, that will be perihepatic abscess, biliary fistula, total hepatic hematoma, urinary complications, coagulopathy, and hypoglycemia. Local experience. It is common in Nigeria, in fact, in all parts of Nigeria, we've had cases of abdominal injuries. They usually occur most often from stab wounds, from civil unrest and strife, and motor vehicular crash. The outcomes are usually satisfactory because most of the centers in Nigeria handle this condition. Local experience in this center, with respect to my own personal experience, well, I've seen 2 cases. The first case was sometime in November, a 30-year-old Haftan cleric who presented with a penetrating abdominal injury. His case was actually a case of attempted suicide. He ingested a lot of detergents, and then he followed it up by giving himself a stab wound. But when I examined, actually by the age of he was stable, all his parameters were, all his vitals were stable. When I inserted, I irrigated thoroughly, and when I inserted the glove hand inside, I was able to see that the stab injury only penetrated through the anterior abdominal wall and stopped short of the omentum. Omentum was not affected. I have called the surgical team on call, and they took over the management of the patient. But